First of all, I want to thank everybody for allowing me the opportunity to speak here. Being a part of this community is something that I actually hold very dear to myself. And whenever I was approached by Rip with the opportunity to speak here, it was a distinct honor, and I'm actually very humbled to be able to do this. A couple of months ago, Rip approached me and said, "Hey, I want you to do a presentation at the Starting Strength Coaches Association meeting." And my first question to him was, "Well, what do you want me to talk about?" And Rip kind of maybe foolishly said, "Whatever you want to talk about." And so I started going through in my mind like all the stuff that I actually do like talking about. Back pain is not on the list of things that I actually like to talk about. I have to talk about it by virtue of my profession. I have to talk about it more often than I ever dreamed possible. And definitely this was not what I wanted to do. But then I had two situations that came up that made me think like, hey, this is the right topic for this platform. The first thing was I had a female come into my office, a new patient came into my office, 20-year-old, by all respects, like completely average, played sports in high school, looked like she kind of, at least in earnest, tried to keep herself in shape. She was a newer onset of back pain, and she was referred to me to go through back rehab, okay? So she came to my office, she sat down, kind of do the brief introduction, and ask her, what are you doing here in the clinic? Like, what is it that you were referred here for? What's the problem? And this 20-year-old female said, and I quote, I don't know how to put this, but my doctor just told me that I have degenerative disc disease at L5, and he told me that I can never exercise again. And this is a 20-year-old, and at first, I'm kind of a jerk. So the first thing is I just kind of like sat back in my chair, like ready to just like let this person know just how wrong that was. But then I kind of stopped myself for a second and thought, man, what a wasted opportunity here. Because no matter what I do with this patient, no matter what I tell them, her first experience or her first memory of being diagnosed with something is that she was told she can never exercise again, and I will never be able to undo that. And bringing this individual into the clinic and trying to impart knowledge to them to say, yes, you can do this, you can do it safely, this is not a death sentence. After 6 weeks of therapy, she was exactly where she started because her doctor told her she could never exercise again. And so in the medical profession, we say, first do no harm. And we've got to split that up a little bit because number one, the doctor tried to not do her harm by saying don't exercise because it may hurt your back. But look at all the follow-on effects of a lifetime spent not exercising because your back could potentially hurt. So there was that. And then on the board one day, I pulled up a back injury thread, and it started out exactly the same way. Kind of paraphrasing, it was like, Rip, I don't know how to put this, but I just had an MRI and my doctor called to tell me that I have degenerative disc disease at L4, L5, L5S1. I don't know what to do with my life anymore. And it was like, oh my God.
The back of a 75-year-old.
Yes, or they say something like, my doctor told me this is the worst back that he's ever seen. And so then, even though this is not what I want to talk about, this is probably actually a talk that for us might be of some use because outside of, we all know that in the medical community that our ability to treat back pain is pretty poor. So what you're going to have is you're going to have individuals come through the medical system and they're going to get treated for back pain and they're not going to get any better. And then they're going to start seeking alternative treatments. Acupuncturists count on this, right? But more and more people are going to start looking at something outside of traditional Western or Eastern medicine. And you start to see this a lot with CrossFit. People with bad back pain are now starting to go to CrossFit because they think that this might be the silver bullet. But the reason why I decided to do this was because there's so much misinformation out there about back pain that it's probably worth talking about, all right? So the title of this is Getting Back Under the Bar. And the reason why I named it that is because whenever people ask me, hey, Dr. Morris, what do I need to do to help my back. And that's what I tell them. You got to get back under the bar. And for virtually everybody I have with back pain, that's my standard prescription. We got to get you squatting. We have to get you deadlifting again. And now how we get there differs from from person to person, right? But the overall technique or the overall end goal is exactly that. All right. So here's a couple of the things that we're going to talk about. We've already kind of talked about the background, why I'm doing this. We're going to talk about some of the epidemiology, relevant anatomy whenever it comes to low back. And what you'll find is with the relevant anatomy and the pathoanatomy of the low back, most of that really doesn't even matter. Because no matter what your diagnosis is, whenever you're talking about back pain, does it really matter if you have a spondylolisthesis? Does it really matter if you have degenerative disc disease or disc space narrowing or anything like that? What is the one thing that joins all those together? That your back hurts. So we're really going to talk about this just in the context of you have back pain. How are we going to fix that, all right? Then we're going to get into kind of the shortfalls of the pathoanatomical approach and the traditional kind of mechanical thinking of how we experience pain, talk about the biopsychosocial model of pain, and then I'm going to make some recommendations for for you guys, right? Make some recommendations, then we'll take a couple of questions. Let me preface that by saying whenever we talk about, or whenever we get to the question, I'm not answering specific medical questions about your particular situation, okay? Let's keep the questions in line with what the presentation's actually about, all right? So a little bit of a background about myself. I have a bachelor's of exercise science from Lubbock Christian University. I graduated in 2003. Joined the Army shortly thereafter. I've been active duty ever since then. About 2010, I made an application to Baylor University's Doctor of Physical Therapy program. I was at a point in my career where I wanted to do something different because what I was doing then, it was like Office Space, right? Like every day was the worst day of my life. Like I was just waiting for somebody to steal my stapler because I just hated my job, right? So at the time I was your typical gym bro. I was part of the chest and curl club. I'd go to the gym every Monday, every single Monday, and I would knock out my 3 sets of 8 to 12 bench, 3 sets of 8 to 12 on incline, and that was my training history. And I thought, well, I'll go to physical therapy school because I like to work out, so this will give me an avenue to kind of talk about that all the time. All right, became a starting strength coach in 2012. I actually met Rip in 2010. I had just gotten back from Afghanistan deployment, and I was getting ready to go to, I had just gotten back from an Olympic combine, and I had just been picked up as a U.S. Olympic Committee funded athlete. And I had started kind of dabbling in the starting strength method, right, whenever I was deployed, and started to kind of see the benefit of that type of a training versus what I had done for years and years before. And then actually, whenever I got picked up for physical therapy school, we had Rip out at Alaska, where I was stationed at the time. He was doing a seminar for my battalion, doing a lifting seminar for him, and I think you were the first person who actually found out that I got picked up for physical therapy school. Yeah, it was kind of cool. And the first thing he told me was, "You just fucked up." And I was like, wait a second, you know something that I don't. I have a very modest academic record. I have an even more modest, maybe poor academic or athletic history. I have had some good opportunities though. Like I was able to train at the U.S. Olympic Committee, the U.S. Olympic Training Facility at Lake Placid several times as part of the National Development Program for the Winter Olympic sport of skeleton. It was a lot of fun. And then I also have done some competitive powerlifting. I was an Alaska state record holder in a couple of events in the men's open 165 pound class. All right. So the disclaimer here is this lecture is for educational purposes only. All right. This is just me kind of giving you kind of a smattering of my own personal beliefs, some of what the literature says, though what I give you from the literature is more of a narrative review. I kind of picked and chose articles that kind of support what I'm going to say, because if you look at the literature for back pain, the literature is very clear that nothing is clear, right? That really the only thing that we can tell you is that NSAIDs work and that you should probably exercise, and that's about all we really get out of it. Now, whenever it comes to back pain, every situation is different, all right? Every situation is different, and some knucklehead like me standing up here talking to you, like, I can't address your particular problem, all right? So what I'm telling you is not specific advice for you, nor should it be taken as such, all right? So from a liability standpoint, this is not...
What did he tell you this is?
No, this is all me. All right, so what I'm telling you, like, I'm not telling you this so that you can go out and diagnose yourself, diagnose your trainees. I'm not telling you how to treat this. I'm just giving you some education on this topic so that whenever people come to you, you have a little bit of knowledge so that you can talk a bit more about this than your standard, like, personal trainers, all right? And
not that Dr. Google guy we keep hearing.
No, I'm definitely not. And even though it almost pains me to say this because of different experiences that I've had and experiences of some of my patients, this is not to be used as a substitute for medical advice or treatment from your physician. If you go to your physician and your physician says, John, you can never exercise again because of your degenerative disc disease, it is up to John to decide whether or not he is actually going to heed that advice or not. It's not for me to second guess them. All right, so whenever you look at, so we know if you look at the board, probably, what did you say, maybe 30 or 40% of the injury questions that are on the board have to do in some form or fashion with back pain. And if it doesn't start out as back pain and it starts out as shoulder pain, usually several posts down by the original poster, what you'll see is they say, oh, by the way, I tweaked my back, all right? And so just by looking at the board, you're probably looking at 30 or 40% of board posts about injuries are back pain. And that's actually kind of in line with what statistics tell us. The point prevalence of back pain is about 12%. So that's, if you take all adults in the population, at any given point in time, about 12% of people are going to have moderate to severe back pain. All right, 12%, that's about 1 in every 8 people here. And I bet if we were to poll here, we'd probably have a few people at least that have moderate to severe back pain, all right? In 1 month, so if instead of just looking at one point in time, if you look out over the course of an entire month, it's 23%. So we say now instead of 1 out of every 8, now we have 1 out of every 4 people is gonna experience an episode of moderate to severe back pain. If you now draw that out to an entire year, it's about 38% of people. So you notice that as we look at bigger and bigger segments of time, a bigger proportion of people are going to have that. And this is looking not just at the United States, this is looking globally, all right? This is large studies that are looking at global incidence of back pain. And then if you look at the lifetime prevalence is a little bit weird, but some studies, especially this one by, I'm going to butcher his name, but Manchikanti in 2014, said that the lifetime prevalence of moderate to severe back pain in adults is 40%. Other studies have estimated that to be as high as 80%. So somewhere between 4 and 10 and 8 out of every 10 people are going to have moderate to severe back pain at some point in their life. Now, most of the people, about 80% or so that have back pain, they have an episode of back pain within 6 weeks, they're better, and then they have this long period or long relapse where they don't have any pain at all. And that's where most people fit into. You have about 5 to 10% of the population that have back pain, and 1 year later, they've had continuous back pain for that entire year. And about 5% of the population that have back pain account for 75% of all disability payments whenever it comes to back pain. So look, the lifetime prevalence somewhere between 4 out of 10 or 8 out of 10, but only 5% of all those people account for over 3/4 of the amount of disability related to low back pain. All right, so we see it on the board and we see it in real life that it's a global epidemic. And what that tells you is it doesn't matter if you're looking from the medical perspective, if you're looking at the physical therapy perspective, the strength and conditioning world, or if you just look at general population, right? That nobody has a really good handle on back pain. And as an industry, if you were to just take low back pain treatment as an industry, it's worth $26.3 billion a year just for the treatment of low back pain. All right, so whenever you look at the literature as it relates to back pain, or whenever you look at places like Laser Spine Institute or some of these places that offer these kind of novel approaches to treating back pain, you look at the literature and you look at how the literature doesn't really say that any of this stuff is very effective, but if you can come up with a novel approach for treating back pain, that could potentially be a very, very lucrative opportunity. It could be a very lucrative opportunity because there's $26.3 billion being spent on this. If you can get even just a small portion of that, and 80% of the population has it, you're going to have plenty of clientele. All right, so let's look a little bit at the relevant anatomy, because this is like something that everybody whenever they look at a spine, they can say, yep, that's a spine. But whenever yeah, you're absolutely right. That is a spine. There are many parts of the spine, and it's not so much that you guys need to know what these are from your perspective. What you need to know from your perspective is that the potential trainees are going to come to you, or even trainees that you already have are going to come to you, and they're going to have things like X-ray findings, they're going to have MRIs, they're going to have some type of diagnosis or something that they bring to you and they say, my doctor told me that, craziest thing I've ever heard, guy came to me and I asked him what's going on, and he said, my doctor told me my discs are basically dissolving. And so this poor guy with dissolving disc disease that, so I'm going to give you like some of the relevant anatomy so that whenever you hear some of these terms or some of these diagnoses, you at least know what they're talking about, which you guys probably already do, but we're going to review it anyways because I've got to find something to fill up the time, right? So we'll go over this, and that way you have some familiarity with it. And then for you guys, what's going to be even more powerful than just being kind of familiar with it is looking at how these different parts of the spine, like what they actually do. And then whenever it comes to the pain that your trainee is having or your potential trainee is having, you can say, yeah, that's not what it is. And this is how we're going to take your training, all right? So the relevant anatomy, first of all, of course, you've got the vertebrae. You've got the intervertebral discs, which the intervertebral discs are that's the sexy topic, right? That's the Maxim magazine of the low back, because that's what, whenever you go to the magazine counter, like if you're a dude, like that's the first thing that you're gonna go to, right? They get the most press because they're the most poorly understood in the entire spine. That is the actual structure that is the most poorly understood. You have the intervertebral foramen. Those are important because the way that the spine is set up is the spinal cord comes down, pieces of the spinal cord kind of peel off, and those now nerve roots come out of those intervertebral foramen, all right? You have the central canal. That's really important to us, right? Because that's where the spinal cord, and then if you get down low enough, then you have the cauda equina. Those are two potential structures that we would be best knowing what those are. The facet joints, and then the pars interarticularis, which is relevant for someone who comes to you and says that they have a spondylolisthesis. And then we'll also talk a bit about the core and what that actually means. Because about 100%, maybe even more, of the patients that I have that come in with low back pain, that was what they were told by their doctor. Their doctor gave them some NSAIDs, gave them some Tylenol, told them, hey, just chill out for about 6 weeks, and then you need to go strengthen your core. And so whenever they come to me, because I'm in charge of the low back rehabilitation program for the medical center that I work at, whenever they come in, then they tell me, yeah, my doctor told me that I need to do some core strengthening. My first question to them is, well, what's the core? And most everybody's going to say, well, it's my ab muscles. Like, yeah, that's bullshit, all right? So, we tell people all the time, hey, you need to strengthen your core, but we don't have any fucking idea what that actually means. But we're going to talk about a little bit what that actually means, all right? Okay, so...
That's a spine.
Yep, that is a spine. And this is the only picture that I could find on the public domain, Tom, that is a decent representation of the spine. Okay, so we're looking at the vertebrae and we're looking at multiple angles, all right? Generally speaking, most of us are going to be most concerned with the lumbar vertebrae, all right? And there's a couple of reasons why we're most concerned with the lumbar vertebrae whenever we're, like in our profession, all right? The way that you know that even if you had no idea what segment of the spine this was, one of the things that keys you into that this is part of the lumbar spine is the shape of the spinous processes, all right? You see up here, these are thoracic vertebrae. You see that their spinous process is a little bit more pointy, a little bit more narrow. As you get down into the lumbar vertebrae, they're what they call hatchet shaped. I've never seen a hatchet that looks like that, but that's what they call it, all right? But this is how you know that you're now in the lumbar vertebrae. So this would be L1 and L2. All right, most of us, if we've ever seen any type of imaging or anything like that, this is the view that we're most concerned about, or this is the one that we're most familiar with, right? Because that looks like a spine, right? Now, if you take a look at it, and if you were to look at this from the top down, if you look at this from the top down, this would be the front, this is the back, all right? You have this, which is the vertebral body, which is what, whenever we talk about the vertebrae, that's mostly what we're talking about, right? And then the intervertebral disc sits right on top of here. All right, but it's the general shape of the vertebrae. And you see that this little hole, or what we call foramen right here, is where that's the central canal, all right? So that's where the spinal cord, or if you get down low enough, that's where the cauda equina, that's where it resides. Now, if you look at this, so if we say this is the front, this is the back, why is it that we have more problems with a posterior disc protrusion than we do anterior disc protrusions, or herniated disc, or slip disc, or dissolving disc, or whatever term you want to use for it? The reason being is because the central canal resides at the posterior aspect of where the disc resides, okay? All right, speaking of the intervertebral discs, this is where they would reside. So Henry Gray, whenever he decided to draw these back in the 1800s, he didn't draw them with the discs in here, but this is where they reside, okay? Now, one thing that I absolutely despise this term is whenever people say that they have a slipped disc. Whenever people say that they have a slipped disc, like it's a total unicorn, like that doesn't happen. The reason why that doesn't actually happen is because the discs are not free floating in between the vertebrae, okay? They are actually attached to the vertebral end plate, and the disc does not move. It does not slide. It can't. If it does, then that is a fairly radical musculoskeletal problem that you have that probably needs to be addressed very quickly, because things are about to get really fucking crazy for you, all right? Yeah, things are gonna get really, really janky for you real quick, all right? This is where the intervertebral discs reside. And then if you look over here on this, like I kind of drew about as best I can with PowerPoint where like the amount of space that disc would take up, all right? And then that brings us to the intervertebral foramen. All right, so as I said a little bit ago, you have, once you get to about L2, it's a little bit different, but before that, the spinal cord is coming down. It's a collection of axons. And as it comes down, pieces of that peel off, and then they exit out of the spine through these intervertebral foramen, all right? And then now as they exit out of that, they go and then they join with other nerve roots to become the big named nerves that we have. Everybody knows at least one nerve, right? Sciatic, right? Because everybody's got sciatica, right? And so anyways, what you have, the sciatic nerve is a collection of nerve roots that come out of the intervertebral foramen, join together, and then they kind of go down through the body, and they become the named nerves, all right? This becomes important to us because there is a limited amount of space in that foramen or that hole, in that opening, right? And anything that creates some type of space-occupying lesion in this could potentially cause us problems, right? Because the nerve is kind of not poorly, or I guess not generally understood, is that nerves have to move. There is a certain amount of stretch, there's a certain amount of glide to nerves, and it's not so much just compressing a nerve that causes problems, it's compressing the nerve and then that nerve trying to slide or move or glide just a little bit as it's being compressed that causes problems, all right? So we're interested in the intervertebral foramen whenever there is some type of space-occupying lesion in there, whether it be a herniated disc, whether it be a bony overgrowth, or something like that, all right? Or even if it's just a swollen nerve root, right? So if you have like a radiculitis and that nerve root swells, it now occupies more of that space, and so there's a compression of that nerve, all right? Now, don't have a great picture of the spinal cord, but you guys all know what a spinal cord looks like, right? Everybody's played Mortal Kombat, so they've at least seen you've seen that, right? All right, so generally speaking, most people, the spinal cord is going to terminate somewhere between L1 and L2. It just so happens that Henry Gray, whenever he drew this picture, that this is L1, this is L2. Somewhere in that space or that range of vertebrae, you're going to have the termination of the spinal cord, and it's going to become what we call the cauda equina. The cauda equina, or horse's tail, is now, instead of being a collection of those nerves into one central cord, now it just becomes a bunch of nerve roots essentially that come down off of, that just kind of descend down the spine, all right? And there's a big difference between a lesion at L1 or above or lesions at L2 and below. There's going to be an entirely different presentation. And so there are things that people can come in with that you could say, yeah, that's probably, you probably got something going on at L3, L4, L5. But when people come in and they have some type of space-occupying lesion a little bit above that, or even worse, if they have a central canal space-occupying lesion, they're going to have an entirely different presentation. And it's going to be it's going to be entirely different, all right? But the difference is above the termination of the spinal cord, right? Above that is going to be, you're going to see upper motor neuron type symptoms. So that's going to be like hyperreflexia, increased tone, spasticity, stuff like that. You're going to see that in like central cord or central canal stuff here. If you go down below that, you're going to see more peripheral nerve or lower motor neuron stuff. So you're going to see weakness, you're going to see loss of reflex, you're going to see lots of sensory changes and stuff like that. Generally speaking, most everybody that you see that has some type of lumbar pathology or something that's actually diagnosable is going to come in with an L4, L5, or S1, all right? And the reason being is because if you look at the spine, that we all kind of have some mental idea of what that looks like, it works kind of like a chain, right? And these intervertebral discs, as we step on the ground, as we do any type of thing that exerts force into the ground, we get a ground reaction force that comes up. That force travels up it travels up the bones of the leg, right? And it comes through the SI joints, through the hip SI joints, and then travels up the spine. So it would just, it's intuitive, right? That the lower down on the chain, the closer that chain is to the actual ground reaction force, is going to have more force going through it. Now those discs are a little bit buoyant, so whenever the force travels up there and it hits that first disc, some of that force is dissipated. Goes up to the next disc, some of that force is dissipated. So the cumulative or the overall stress on the lower discs is much higher than what you see going up. And then you get to the point where about T10, T9 or so, you almost never see any type of herniated disc in that in that area except with trauma, all right? But then you go all the way up to the top, and then guess what? Now you start to see a lot of herniated or disc herniations and pathologies in the neck because it works exactly the same way. Whenever that big melon of mine like whips around, whenever I try to run or something like that, more force is generated on the higher cervical discs, gets dissipated as it continues to go down. That force is dampened, and then you get to the point where there's very little force that's traveling through there at all.